Thanks, guys. You made it feel so fancy. So I just want to talk to you guys about how to navigate beta-lactam allergies. A lot of the stuff that will be in this presentation are things you might already know, so I just am hoping that I'll give you a new perspective about how to think about it. So there's nothing to disclose in this presentation, and our objectives are listed here, so I won't read everything up there word for word, but just know we're going to go through a lot of different things. Hopefully I'll keep it interactive for everyone, so try to participate if you can, because it's more fun that way, for me at least, maybe not for you. So before I start, I wanted to ask you guys a question. Maybe we can either go around the room or you just can shout it out, but tell me one thing you know about beta-lactam allergies and maybe any issues that come up with them.
I know that it's had a lot of issues in terms of stewardship problems, like AZTREONAM, jumping to higher in the chain type of antibiotics.
Yeah.
That's a big part of the problem.
Yeah, you definitely end up choosing alternatives to things.
A lot of times it said we have a penicillin allergy, but it doesn't list you what the allergy is, you know?
That's a major problem.
Yeah.
And then a lot of times you get a vague history about I had the allergy, but in childhood, and no one really knows what exactly it was. So
Yep, that's
Yeah.
that's all true. I have my favorite story is I actually interviewed a patient about their allergy, and she told me that she's one of 5 children, and 2 of the 5 really did have an allergy, and the mom couldn't remember which 2. So she made all 5 of her kids allergic to penicillin. So like at least 3 of them are allergic and not. So that happens all the time. So those are good ones, and those are all things that we're going to cover. So not you, unless you have something new to add.
Yeah, I mean, I just think it results in a lot of higher spectrum, broad spectrum antibiotic use, maybe when it's not needed. So it's really helpful for stewardship reasons.
I think also the vagary of the allergies and what's reported, a lot of times it's hard to differentiate maybe whether they've taken a cephalosporin or a plain old penicillin. You know, a question I typically ask is, do you remember taking the pink stuff? Because everybody remembers the pink stuff.
Like
Dr.
amoxicillin.
Tony, you remember the pink stuff, right?
I can neither confirm or deny.
He walked in late.
I know, he's like, what is happening?
But that's how most kids remember taking amoxicillin. Is they get
The polio vaccine?
the bubble gum.
Sugar cube.
Oh, goodness.
But anyway.
Yeah, so those are definitely ones. Some things that didn't come up that I would love to point out is that roughly, like statistically, about 10% of the population says they're allergic to penicillin, and actually less than 1% of the population is actually truly allergic. So that's a staggering number, like big difference. So all of the things that you guys mentioned kind of fall into those statistics. And then the other thing, and so a lot of those like 90% end up being drug intolerances, so maybe like adverse effects they had, whether it's like nausea, vomiting, diarrhea, or something like that. It could be they have no earthly idea and their mom is allergic, and so they put it in the chart as well. And then the other cool thing about penicillin, it's a little different than some other hypersensitivity reactions, is you can actually lose that sensitivity over time. So even if you did have a true allergy when you were a kid, you know, 10 years later, that sensitivity can drop by 80%, and as you get to 20 years later, that's even less, and then 30, 40. And when you're thinking about, especially at the VA, when you're seeing veterans, like they're not all, but a lot of them are, you know, over the age of 60, over 65. So these reactions were when they were in the military or when they were kids, and you're talking there 40, 50 years ago. So there's also a chance that that hypersensitivity might have gone away. So these did come up. So beta-lactam allergies have been linked to increased antimicrobial resistance, use of broad-spectrum antibiotics, use of less efficacious antimicrobials, and we'll talk about that. There are studies out there that actually say they've been linked to like longer hospital stays, which is really huge for hospital sites, that, you know, that's a problem for them. A lot of times it causes you to stray away from first-line guideline recommendations, and it just overall costs the healthcare system a little bit more. So those are some big things that really play into this as well. And then the last component, stewardship, did come up when we went around. And so in 2016, the IDSA stewardship guidelines do actually recommend doing antibiotic allergy assessments, particularly for penicillin, and even penicillin skin testing as one of the stewardship objectives that you can do throughout the year. So that's another cool thing. So when you're, especially for the fellows, when you guys go get jobs, if they're in stewardship, like this might be something that your sites want you to focus on. So the next thing we'll do is talk about the classification of different hypersensitivity reactions. And you guys should hopefully be probably even more familiar than me with some of these reactions. But my first question for you is actually going to be, before we go through all the different types, I want to talk about the difference between an adverse drug reaction and an allergy, and we've touched on it a little bit, but do you guys know what the difference between those two are?
Like diarrhea would be an adverse drug reaction, but not necessarily an allergy.
Mhm.
Like drugs no one can do it.
Yeah. So I always think of an allergy can be lumped into an adverse drug reaction. So that adverse drug reaction is kind of like the balloon over everything, and then the allergy is a subcomponent of it. And the allergies, when we usually think of this, we'll think of like your true like type 1 IgE mediated hypersensitivity reactions, or the other big one is your type 4 hypersensitivity reactions. So those are people that are really developing hives, rashes, even, you know, if the type 4s, so like Stevens-Johnson's and things like that. So they kind of lump together. And the reason I bring this point up is because I thought of it from the VA perspective, is when you look in that allergy box on the cover sheet of your page, or when we do that, it's not just allergies. So that's allergies and adverse drug reactions. So it's important to, and I think most of us do this, but click on it and see what it says in there. Now this came up too, a lot of times it's blank, so it doesn't help you, but sometimes there is really good information in there that can help you determine, was this a true allergy or was it not a true allergy? So that's why I thought this was really important to cover. And we talk, so I mentioned some of these things, but we talked about what an allergic reaction was, and the most common causes tend to be antibiotics. So that's why a lot of people jump to the conclusions if somebody has an allergy, usually they may call us or allergy to get involved. But anticonvulsants can be pretty high up in that list. Chemotherapy is another big one that causes some of these symptoms. Monoclonal antibodies, which are starting to become a lot more common for patients. And then NSAIDs can also, those are like your top allergy causes of drugs. So when you break down allergy reactions, they can actually be broken down into type A and type B. So they're essentially, the difference between these are that they're either pharmacologically predictable or pharmacologically unpredictable. So your true allergies, your type 1 to type 4 hypersensitivities, those aren't things you can predict in a patient. Whereas like a type A reaction, let's think of, it's not a beta-lactam, but let's think of vanco. So vanco is a nephrotoxic agent, right? So you know that pharmacologically this can be hard on your kidneys, and you may see increases in creatinine. Another drug I think of, same situation where you can see creatinine increases. When you start a patient, like an HIV patient on a cobicistat regimen, you may see that bump. And that's something you can pharmacologically predict that this may happen, and we need to monitor for it. Whereas those type B reactions, 1 through 4s, you really don't know who's going to get these, and so you just have to be prepared to handle them when it happens. And so this is just a visual representation. So if you guys are interested in the slides or whatnot, I can share it with you. But this is just a table that talks about what each of the 4 classes are. So the big ones that we'll go over are your type 1 hypersensitivity. So those are your angioedema, anaphylaxis, hives, those kind of things. And then type 4s, we'll talk about the differences in like DRESS and TEN and stuff like that. So I'll just quickly go through each one of these. So these drug eruptions are pretty much, I didn't know. I was like, oh no, did I stop him from eating? No. I was worried. I was like, I should have warned you guys. There's pictures. They're not all that bad though. So these drug eruptions, they account for about 80% of drug rashes. So this is like your most common one, and they usually appear pretty early in the initiation of therapy. So, you know, a few days afterwards, but they can take a little bit longer, up to 21 days. They can be, you'll probably hear them documented, or you guys will document them in the chart as either maculopapular rashes or morbilliform eruptions. And they can be widespread symmetrical rashes, and sometimes patients may have fevers or things like that to go with them. And a lot of times the duration of how long this reaction will hang around is related to the half-life of that drug. If it's got a long half-life or their renal function's not working great, it can take a little while for that to resolve until you can get it completely out of their system. Urticaria is a little bit less common, but these are some pictures. It counts for about 5 to 10% of drug rashes. And a lot of patients can just be asymptomatic and like they just suddenly have a rash. They can have some itching, and it'll tend to have like that central blanching look and red rims, and it lasts less than 24 hours. But like I said, you guys are going to be more experts at this than I am. I'm not really diagnosing these things. And then the other ones that are not really your type 1 hypersensitivity, these are like your type 4s, and this will come in later, are things that are classified as scars or severe cutaneous reactions. So that's your Stevens-Johnson's, your 10, DRESS, and AGEP, and we'll just go through those quickly. So Stevens-Johnson's and TEN are lumped together. Most of the time when these do happen, it is drug-related, about 80% of the time. It can happen fairly, moderately into, 4 days into therapy, a little earlier even. And it is a pretty severe reaction. It does have high mortality associated with it. And a lot of patients will have severe blistering. And the big key thing you want to look for is mucous membrane involvement. And then there's DRESS as well, which I know usually allergy will get involved to like fully diagnose whether it's a true DRESS reaction, but patients tend to have widespread rashes. They can have facial edema and erythema. They can have fevers. They can have eosinophilia, lymphadenopathy. So a lot of symptoms can happen in these patients as well. And then the last one, or there's 2 more on here actually. So then there's there's AGEP, which about 50% of these cases are drug related. So sometimes they're related to other conditions, but they usually occur a little bit earlier. So, usually in the first few days of therapy, like less than 3 days. And patients tend to present in the body folds. So you may see it in like armpits or like that elbow fold. They can have facial edema, fever, and they have neutrophilia. So you start to see a lot of these patients have a lot of the same symptoms. So it's really hard to distinguish which type of rash they have. And then to make things 1,000 times harder, there's also non-drug rashes, and they can look kind of similar to drug rashes. So, and patients can present with really similar symptoms. And some of the conditions that you might see them in, if a patient has measles, and I bring that up because we know that's been a popular thing in the news. Strep pharyngitis, HIV can present with rashes. So there's a lot of different conditions where you have to, ask yourself, is this drug related or is it, related to a condition? So it takes a lot of things, and I think we're all very thankful that we have physicians like you guys to help us do all of that stuff. So just things to keep in mind as we go along. So the next thing as I transition, so that's kind of like our introduction, get us going. So I really want to start off by talking about beta-lactam allergy documentation. So Harish, I know you brought this up, that a lot of times you click on it and it says nothing, right? So that is really common. So I wanted to show you guys, how many times have you opened up a chart and seen this where it says penicillin, unknown, and historical? All the time, right? This is just super common. So this is a problem, and it's a problem I think that, and we can talk about it as the presentation goes along, but I think it's a problem that we can't completely fix. I don't know that we can prevent everybody from doing this, but you guys, I know, you go see a patient, you ask them about their penicillin allergy, you go to rounds, and like the pharmacist will tell you, hey, we looked and saw that they've tolerated all of these drugs, and you get this really good history, and then you're finished seeing the patient, we sign off on them, and they go about their business, but did anybody do anything about this? Not always, right? So it's something that we can do. It's a simple thing. We can always update the allergies, and we can work together as a team. Sometimes the physicians can do it. Sometimes you can ask your pharmacist to do it. But I want you to think about, so when you see that allergy, I just want you to think about these situations. So think about, you get a consult for a patient that needs to be treated for syphilis. Yeah.
Then, you can fill it in. So would you fill it in saying like, hey, the patient was able to tolerate this medication, this medication, this medication?
Yeah, so I'll show you an example actually after we talk about these. So think about it, you get a consult for a patient that needs to be treated for syphilis. They've got that unknown penicillin allergy, and now you're kind of like, crap, what am I going to do? Because penicillin's your drug of choice. So you have to really decide, you have to get a good history and find out, is this patient a candidate to maybe just challenge, or do I need to move them up to the ICU and do some desensitization so I can treat them? Another situation to think about a patient that had that beta-lactam allergy, maybe went to their primary care provider, got prescribed fluoroquinolone instead for their condition, developed C. diff, and now they're coming back to see you in the clinic to get treatment for their C. diff. That's something that could have totally been preventable, maybe if we had a little bit better history for the patient. Maybe it wasn't preventable, but could have been. Other situations, these are a little bit more severe, but like think about those patients that come in for orthosurgery and they've got a penicillin allergy and they're growing MSSA, so they get just put on Vanco instead of Ceftazidim. and they have this surgical site infection. And it's actually been shown that in this group of patients, there was a study published, and here's the title of it, but essentially these patients, there was a 50% higher odds of those patients actually developing recurrent infections after their orthopedic surgery if they got Vanco over Cefazolin for MSSA infections. So there are some like poorer outcomes with that. And this is a similar situation, but instead maybe they got Vanco instead of Cefazolin, but this time, you know, their mortality was higher and they pass away. And another study showed, whoops, I went too fast. Another study here showed that patients that end up with Vanco instead of Cefazolin, if they could get Cefazolin, actually had like a 70 to 80% higher mortality rate. So there are some staggering outcomes with that. And then the last one I just like to think about, and these are situations I see all the time, is patients that get started on AZTREONAM. So I know Vidya brought this up as well. But you start them on AZTREONAM empirically, but maybe they're not getting better on that and they're not doing well. So this is a little bit old data. It's from 2014, but this is the antibiogram at the VA in 2014. We don't put AZTREONAM on it anymore, but back then you can look and see for Pseudomonas. So if that's what you were trying to cover, we were 47% susceptible. I'm sure that might be a little bit better today because we're not using AZTREONAM as often, but you're still talking, you're missing a good chunk of Pseudomonas by using some of these alternatives as well. So the reason I bring all of this up, and this goes back to yours, Harish, is we can update the allergy. So here's an example. This is one where we can see that the patient had urticaria, and it's just summarized. So it looks like this patient was interviewed by a pharmacy student and told us that he had an allergy when he was about 17 years of age. So that was more than 50 years ago in this patient. He got an IM injection, and immediately following that injection, he got what he called small red bumps all over his body, which we thought, or on his arms and feet. We presumed those were hives, and he told us he didn't require any treatment to treat his hives. But so since then, so nothing really happened from there, but since then he's tolerated Keflex in the years listed, ceftriaxone and cefepime without reaction. So that, having that updated in your chart, do you think that would help you guys decide what options you have? It's a lot better, right? Yeah. So I think that that's super helpful. So just when you think about it, and not just here, I don't know what other, I don't know how Moffitt and TGH are set up or where your future practice sites are, but if you have an allergy that doesn't have anything and you have the option to update them, then like take the opportunity, I think, and try to do that. If you took the time to get the history, because you don't know how many times have you been reconsulted on a patient? Let's go there. And then you have to do this all over again. You'll pat yourself on the back 1,000 times. I've updated allergies and I get new patients when I switch services and I'm like, yes, this got updated. Or one of my colleagues updated it. I'm like, great, somebody in pharmacy updated this. This saved me, 5 to 10 minutes of chart review or patient interview to get this information. It's really helpful. So other things, so allergy documentation is a problem everywhere. Yes. Mm-hmm. When he got, it was,
some outpatient providers do, and they would give them, it's a combination of penicillin. Remember, there's two.
Yeah.
Penicillin,
Mm-hmm.
LA, which is long-acting, which is for syphilis, and then there's CR, which is a 50-50 combination of long and short-acting penicillin. That was the one that inappropriately gets given to treat syphilis.
Yeah.
People would do that, and why were they giving that? Because usually for sore throat.
Mm-hmm. Yeah, I was going to say, I'm
You know,
thinking
coming
you're
off,
going with,
you bill them for an injection.
Like a mono.
You don't have to worry about PO. Great thing to do. Unless that it's not strep throat.
mm-hmm.
Mono?
I'm sorry.
Mono? Are you talking about mononucleosis?
Yeah.
The react-
Yeah. And how many times do people get a rash with mono to penicillin and ampicillin? 95% of the time. We used to kid and say, it's a better test than a monospot. Give them some penicillin, see if they get a rash. And that's a Hafton reaction. That's not a true allergy. You can come back 2-3 weeks later, give penicillin.
Nothing happens,
So
yep.
That's not even an allergy. But that was the common thing that happened with people, and the history sometimes gives you an idea. I mean, I had an 80-some-year-old guy told me when he was a very small child that, he got penicillin and he had this reaction. They told him he should never ever get penicillin again. When you do the dates, when he should have gotten his penicillin, and it wasn't even released. This didn't get released until 1947. So there's no way he got penicillin, even though he said, my mom said I got it. I said, well, Nothing against your mom, but that's incorrect.
Yeah. And I saw a patient, I think in SCI is where it was, because I tried to do a lot of these interviews, and if I see patients, I try to update it. And I'm pretty sure he literally told me that he got treated with penicillin for mono and developed a rash. And I was just like staring at him almost blankly, like, okay, I have to tell you that this isn't real, without like, kind of laughing because they don't know. And like, I heard it and I was like, this is like an example that I've heard before. So yeah. So, but this documentation stuff, it's not an issue just here. It's not an issue just at the VA or just at Moffitt or anywhere you go. This is an issue everywhere. So there's been a couple studies where they tried to, assess how well are allergies documented. And back in 2008, they, this group went through all their patient charts and saw that, and they looked at all allergies. It wasn't just beta-lactams, but they saw 30% of charts just had no allergy documentation. Maybe it was never assessed for the patient, or they didn't put any sort of extra stuff. Another study in 2008, I think this was actually specifically in surgery patients. So patients that came in for like an outpatient surgery and they got a full pre-op workup, still 24.7% of those patients didn't get an allergy assessment on their full pre-op workup. Imagine what they got beforehand. So it's documentation is missing everywhere. And then in 2011, they actually tried to assess more rather than like, are allergies documented? Instead of assessing are allergies documented in the chart in general, they tried to assess how well do we document them. And only 0.6% of the patients that they looked at had a fully documented allergy. So not even 1% of their patient population was getting a good allergy history. So you're missing a lot. And I know that people ask these questions. I know that we're doing it. It's just not getting documented. And you'll find that it will be helpful. So actually, when I was a PGY2 here 2 years ago, I did this study with our patients to see how well we were documenting them. So we were just assessing who had complete documentation. We looked at 66 patients in a 3-month period, and only 9 patients had complete documentation. So our number was a lot higher than that 0.6, so it was 14%, but still really low. And so this is what it looks like visually, that 86% had maybe some documentation or just really poor documentation of that reaction like I showed you that says unknown or not. So there's a lot of room for improvement. I've actually been trying to go back to see, we did a little bit of education after this, and so right after we finished that to see if anything has gotten better. I don't have any like formal numbers, but education didn't change anything. So I think we all just have to be better as a whole. And this is what we had. I won't read through all these, but that was what we included to be complete allergy assessment for the patients. So the next issue, so we now know documentation's an issue, right? So the next issue is understanding beta-lactam cross-reactivity. So that's why I included those charts on the table. So there's some fun things for you. If you have an antimicrobial book, that should be in the back of your book, but I printed one out in case you didn't bring it with you today. But if we just talk about cross-reactivity, back in the 1970s, it was reported that cephalosporins and penicillins had a cross-reactivity somewhere, in the neighborhood of 10 to 25%. And this was a problem. Nobody wanted, if you went to the, pharmacy to pick up your cephalosporin and they said, there's a 25% chance you're going to have the same reaction you had before, are you going to want to take it? I probably wouldn't want to. So a lot of times people would just completely essentially knock out that beta-lactam class because of this. But back in the early 90s, they actually found out that the cephalosporin and penicillin cross-reactivity was really less than 1%, maybe like 1 to 2%. And the reason for that was actually just due to poor manufacturing practices. So when they would manufacture your cephalosporins and penicillins, they did them in the same facilities, so the same plants. So essentially your cephalosporins were laced with penicillin, which is why you had such high cross-reactivity, because some of those drugs actually had penicillin in them. So a little bit later in the 90s, still kind of early 90s, they actually went ahead and confirmed that the reason for this cross-reactivity is all related to side chains. So it's not that main beta-lactam ring, it's the side chains of them. So we have all these different cephalosporins that all have different side chains. So you can use those side chains in understanding how similar they are to the base penicillin to decide, is there a high risk of cross-reactivity or not. So here's a visual representation. So penicillins to cephalosporins can have a 2% cross-reactivity, and that's due to the side chain. Carbapenems are a little bit lower, just because their side chains are really different. And then your monobactam, so AZTREONAM, I mean, one, its structure looks completely different to begin with, but its side chain is also different. So you will see that essentially has no cross-reactivity, but it's safe. But I will tell you there is one situation, and we'll talk about it in a little bit, where AZTREONAM may cross-react with a cephalosporin. So think if you know the answer. So in terms of this, there was a study that was done, it looks like it was kind of like a review of articles between 1960 and 2007, and they included 44 studies in here. And basically the literature across the board supports the use of cephalosporins in patients with penicillin allergies. The cross-reactivity is a lot lower than what we originally thought, so these are safe to give. So this is something I think that most people are starting to recognize for the most part, but there are some situations where you see a penicillin allergy, they get put on AZTREONAM and roll there. But the literature does support the use in patients with this. So here, so I think the study actually said that patients' side chains were different in 92% of the cases, so those patients didn't actually have any reaction. So it really worked out great, and it was most of the time related to the R1 side chain. So that table in front of you, so you'll see there's the R1. So they are sometimes different in those patients, but it's highlighted there structurally. But I don't know how much you'll actually really think about the structure. But so the table in front of you, it has these organized by their structures. So you'll notice that if they are kind of that very, very light blue, so I know it's all one color, so it's hard to tell, but there is a lighter blue. So let's see, so here these are a slightly lighter blue versus the darker blue down here. If they're the lighter blue color, that means they're identical side chains. And then if they're the darker blue, so it'll be hard for you to see, but you can hopefully get there. They're similar, but not 100% identical. So I just wanted to give you guys an opportunity to use that table and see how to, actually use it in everyday practice. So a couple questions for you. So let's say you have a patient that has a documented allergy to cefuroxime. What beta-lactams would you want to avoid? You can just shout them out when you know. And there's cefuroxime in the middle of the table, if that helps.
There will be a fair for all patients and staffs in the SCI data rooms from 10 o'clock a.m. to 1 o'clock p.m. There will be demonstrations, giveaways, and refreshments. Thank you.
Yeah, cefoxitin's on there. Yep. So here they are. So cefoxitin, it's got a shaded, essentially what you would want to do in this situation is look for the shaded boxes. So if one of the drugs has a shaded box, that means you're more likely going to have cross-reactivity. So cefoxitin, cefixime, ceftriaxone, cefpodoxime, and cefepime would be similar. So you may want to try to avoid those and use a different beta-lactam in that patient because the side chain will be completely different. You can also use this a little bit differently. So here's a question that kind of does ask a little bit of the opposite. But let's say a patient has a documented penicillin allergy, but we have no earthly idea what it is. And so per chart review, you see he's tolerated cefepime several times in the past year. So which beta-lactam would you feel comfortable using knowing that the patient took cefepime? And here I'll show you cefapime's in the 4th generation column. Ceftriaxone. So the reason for it, so we'll go through it. So nafcillin has a different side chain from cefepime, right? So just because you don't know if he's tolerated something with that side chain, you may want to try something different, because if it's different, we know he tolerates cefepime, so you want something with a similar side chain in this situation. Piperacillin has a different side chain, so you may want to avoid that. Cefazolin has a different side chain, but ceftriaxone, it's shaded, so it has a similar side chain to cefepime, so more than likely they will be able to tolerate that for the patient. So that's how you would use it. So I gave you guys a hint that it's coming up. but do you know which cephalosporin can cross-react with AZTREONAM?
So, I don't know the direct answer to that, but I know that at Moffitt, we use ceftazidime. Is there any relation between ceftazidime and AZTREONAM? Is that what you're talking
Yeah.
about? Okay.
So there actually is cross-reactivity to ceftazidime and AZTREONAM. So if you saw somebody in their chart where they were allergic to ceftazidime, there is a chance that if you gave them AZTREONAM, depending on the reaction, that they could have a reaction to that. So that's like one of the, we always say AZTREONAM is the safe one, but there is a risk with those two. And the reason for it, look at the, I mean, these are
Right.
stereochemically different, but they
So,
have the same side chain.
I actually, as a follow-up, I mean, here, I don't see it used often, but there for penicillin severe allergies where we can't use most of the cephalosporins, we use, like, it's interchangeable, and ceftazidime has been used over at Moffitt.
You
That's
could
actually
potentially do that. I think
cost effectiveness.
I think a lot of people, I think that comes down to, I would assume that comes down to teaching methods. Like when you're in school, like from a pharmacy standpoint, I was always taught beta-lactam allergy or penicillin allergy, give them AZTREONAM.
Yeah.
So it could just be teaching everybody's more comfortable going AZTREONAM, but that's a good option because it is different from all the other ones except for that. Yep. So the next component I wanted to talk about is beta-lactam.
And maybe
Yeah.
it has a little something to do with the antibiogram and Pseudomonas.
That could be too.
Abilities between the two
Oh, okay.
Mhm.
drugs. Because
Yep.
it's covering and fever, right?
Yeah.
That's a good one. Yeah, and I showed you guys that AZTREONAM is usually a little bit lower.
I think in some centers too, AZTREONAM in recent years has, from a utilization standpoint, really changed. I think that AZTREONAM from a cost standpoint is a lot more expensive maybe in some centers. I don't know about our facility. So people are looking for alternatives
Yeah.
to the use of AZTREONAM.
Yeah, it is expensive.
Yeah, I know cost is a huge factor there.
Mhm.
That's why they switched over.
Yeah. So, beta-lactam allergy skin testing. So this has been a very big topic that, at least from a ID pharmacy standpoint, we wish that we could penicillin skin test all of our patients right there at bedside, and that would be great because then you would know your answer. You know, can I give this patient a penicillin or not? But that's not exactly something that we can do at this time. But I'll just give you guys an overview of skin testing if you don't know too much about it. It's a two-step reagent procedure that involves a skin prick and an intradermal test. Usually for patients when they come in to get it, it can take anywhere from 45 minutes to 60 minutes. Sometimes, you know, they may make them wait for 15 minutes, and then by the time they set up the second step of the test, you know, you could be here for a total of 2 hours, but the actual testing time isn't more than an hour for those patients. It does have an approximately 99% negative predictive value, so that means if your skin test's negative, then odds are you're probably not allergic to penicillin. I know that our allergy clinic, when they do these, the verbiage they like to use is, they like to say that you are you're at no greater risk than the general population at having a penicillin allergy. So that's the language they will put in a lot of their notes that you might see. And then really the utilization of skin tests and why a lot of people are trying to use it is that it does improve clinical outcomes. So we talked about all the bad things, you know, in the very beginning of the presentation, that this can be associated with longer lengths of stay, higher hospital costs, and just poorer outcomes for patients. So you can really have those improve. You can also, you know, get patients on more narrow spectrum, better agents, and it also reduces healthcare costs. So this is a visual representation of what it looks like. So you start off with the skin prick test, and I'll show you what that looks like. If that comes back negative, you'll go on to the intradermal test, and then if that comes back negative, they can actually do an observed graded challenge where they'll actually expose you to an oral dose of the beta-lactam. So the prick test, basically what they do is they place a drop of solution on your arm, and then they prick your arm to see if you have a reaction to it, and they wait 15 minutes after they prick the skin to see if there's a wheal and flare in the area. Those are the determinants that they use. So histine's your positive control, you should react at the histamine. Saline, you shouldn't react, and then they'll give you the major and minor determinants of penicillin to determine that. And this is basically what it looks like. So they just, you know, draw spots on the arm, so you should have the reaction to the histamine, which you'll see with the positive, and then everything else is negative. So that's a negative skin prick test shown up there. So that means that you can move on to the next step. So the second step of the test is the intradermal test. So this is like when you give a PPD, like they give the little intradermal test. And they do the same thing, so they'll inject the same 4 determinants in there and wait 15 minutes. A negative test is considered no wheal if the wheal is greater than 5 millimeters or 3 millimeters larger than the saline wheal, then they'll consider it a positive test. And so this one's positive here, so you'll notice that they do have, I don't think the histamine's at the bottom, you can't see it, but you can see that they're positive in both situations there. And then the last thing that they'll do, and I know that our allergy clinic does this sometimes, but not all the time, so I don't fully know how they determine this, but you can do a graded challenge. And so this is indicated for patients that have passed both tests. So you have 2 negative tests. Now we'll give you a graded challenge. And they usually guide this to be very patient-specific for what doses they want to give. And this really has, if you did this alone in a patient that didn't have the skin test, if you just did a graded challenge, it's got about a 94% negative predictive value. So there are certain situations where you could just do a graded challenge for a patient and skip the skin testing part. And these are different, this is kind of it's a lot of things up here, but this is different graded challenges, doses that you'll do. So the top line, they'll actually use amoxicillin for penicillin. So they'll start out with 1 milligram of penicillin, then you go to 5, then 25, 100, 500, and 1,000, and make sure you tolerate it. And they'll space those out. Sometimes it can be like 15 minutes, sometimes it can be 30, depending on how long they want to do it. Oh, there we go. I did highlight it for you. So this is an example of one that they have done here at the VA. So I took this out of a chart. So they did it about 30 minutes apart. So they did 1, 5, 25, 100. So they went like that every 30 minutes. So it did take a long time for patients. So sometimes you can't get a patient to stay for that entire time. So you may get them to stay for the first, 2 or 3 doses of it. And then they may send them home with like a 500 milligram dose to take one day with specific instructions to call, and then like 1,000 the next day. So sometimes the whole test can take days if they do the full graded challenge in those patients. So it's not, I think a lot of us know this, but I'm just including this in case. Skin testing is not recommended prior to each exposure. If you're negative skin test, like you can remove that allergy and the patient can always have this. And resensitization can occur, but it's pretty rare. Less than 1% of patients do have that. Non-penicillin beta-lactam skin tests are really not as well validated. So that means patients that have cephalosporin allergies, those really aren't as well validated. So they may not do allergy testing for someone that has a true allergy to Keflex, for example. So it's really for people that have had penicillin. And then penicillin skin testing doesn't accurately reflect cephalosporin. So just because your penicillin skin test negative, if you develop a cephalosporin allergy maybe later, you can't necessarily say that those are linked. And then, so this is why the negative predictive value for cephalosporin skin testing in most of the literature is somewhere around 30%. So penicillin's 99, so that's a big difference. So it's hard to make those calls there. And then just quickly, there is a difference between skin testing and desensitization. So desensitization is indicated for patients that require a beta-lactam allergy in the setting of a true IgE-mediated allergy that like they're gonna stay allergic forever. So the example I always give is patients that need treatment for syphilis. So you would want to give them penicillin, but you'll have to desensitize them. And so this is just incremental administrations of the drug that you're going to give until you can make them basically not have a reaction. But the key thing here is that the tolerant state to this penicillin is lost maybe 24 to 36 hours later. So we're talking, one day later, if you gave them penicillin after you've, if you've stopped consistently giving it to them, they've missed doses, 24 hours later, they will be resensitized and can have a severe reaction. So you want to make sure that you consistently give the doses if you do it.
How long does it take to sensitize, or is that patient dependent?
It's patient dependent, but I'll show you what an example of how they do it. So this is kind of the pre-meds they'll give. They'll give Benadryl or hydroxyzine, famotidine or ranitidine, and then lorazepam and dexamethasone as their pre-meds. And then this is actually what an order looks like. So they give these doses. Usually I think they can do it, each dose is every 15 minutes. So you can pretty much have them sensitized in a day. But it does take, it's pretty intensive. I've only seen it done once here. I don't know if you guys have seen it more often than I have. But it took somebody was essentially with the patient, they talked to the nurse for a long time, and it's done in the ICU, so they can have somebody basically one-to-one there. But you can do it same day. Yes.
Yeah, I wanted to clear this up because I heard it before. It involves the subject of skin testing. So I think we've been told in the past by Allergy that if a patient has a history of anaphylaxis to penicillin, even if it's in the remote past, that they cannot be skin tested. They have to be desensitized instead. Anybody heard that? So that kind of adds to the complexity of assessing an allergy, because a lot of these, vets who are 80 years old, 70 years old, who were exposed to penicillin had a sketchy history that was supposedly sounded like anaphylaxis. Then you're back to the stage that you can't really skin test them, and then you have to get them in for a full-blown desensitization protocol, and that can be so. That's kind of a challenge with some of the historical. So I think it helps to clarify that allergy with them and really nail it down, because a lot of times you're back to this square one where they can't be skin tested, and they, it's cumbersome to bring them in for a desensitization, and then you have to go with some other agent.
Yeah, and what I've been doing is I try to get a good history, and I just put in an allergy consult to them, like an outpatient one, to have them see them at some point in time in the near future. And I usually word it, and I don't know, I haven't had any canceled or them tell me no, but I just word it, could you further assess this allergy and potentially skin test if the patient's a candidate? And that's usually how I've worded it. And they've at least gone in there and tried to get a little bit better history and maybe ask some different questions. And Jayla and I are working together to track, like, how long is it taking them to get in there and how much. And so we're kind of in the middle of that data collection, so we'll see. But I haven't come across any that have been canceled that we've put in that have been anaphylaxis. So maybe they're taking them. But we've been trying it anyway.
Since you keep bringing it up, this diagnosis of syphilis.
Oh yeah, this is just the easy example.
Two issues with that. One is that what happens sometimes when you treat people with primary and secondary syphilis with a long-acting penicillin.
Oh, it can hang around
Penicillin.
for a long time. It hangs around for a long time. Is that what you're meaning?
Well, that's potentially an issue. So if they have a true allergy, maybe, but that's kind of unclear. What can happen?
Highlight gynular reaction.
Mm-hmm. Yeah. Yeah. Yep.
Which can, if they don't have a rash, they can get a rash. If they had a rash, secondary syphilis could get worse.
Mm-hmm.
And I think that's what some people, they don't remember what was going on, or they don't want to tell you, and they had a GH reaction. That's also a happen reaction.
Mm-hmm. And they can.
You get penicillin later, it's not a problem, but that's what gets reported. We don't get the whole thing. The other one that's an ongoing issue is you have a lady who has a history of a not clear penicillin allergy, who was pregnant, who has syphilis. Now what do you do? Are you going to give her doxycycline? Probably not, although there is some data doxy doesn't cause the issues. It was tetracycline, but nobody's going to take that chance. And so, you're going to give her, after quote desensitization, penicillin. Do you just give her the penicillin once a week for 3 weeks, or do you have to supplement it with some penicillin, or that data is kind of all over.
I was going to say there's not a good answer for that.
There's just an emerging infection network thing on that not too long ago.
Mm-hmm.
One of our past fellows sent me an email, and I said, look, here's all the data. I'm okay with giving it once a week because it seems to last almost the whole 2 weeks. But there are other people that may disagree with that.
And want to give something in between.
So I think that we won't get it as often here, but if you were elsewhere.
Yeah, that may come up for sure. So the last part of the presentation is just what can you guys do. So we've talked about stuff throughout the presentation. So what are things that you think just after this presentation, is there anything that you might do differently in the future? Anybody?
More detailed history.
Mm-hmm.
That's the key.
Yep.
Document it.
And document it, yep. So those are really the big things. So just ensuring that you get a really good assessment of their allergy, document that allergy. So at least in CPRS, there is no way to just edit, I will tell you that. So you have to actually there's a button in there. When you click on it, it says entered an error. So you do have to enter it in error and then re-enter the allergy in order to edit them. So just so that you know.
I might chime in too that a lot of patients don't recall getting penicillin VK or penicillin shots, but they do recall getting amoxicillin. That's why I always like to ask about the pink stuff. Because people remember that, and if they are sure they got the pink stuff, then they can tolerate penicillin. They can tolerate amoxicillin, and I would, revise their penicillin allergy with that.
Could be.
That's what I thought when you said.
Well, if they recall getting Pepto-Bismol for an infection, then they got a bad doctor.
That's funny.
Unless it's a dyspepsia or something, and then you can clear that up with your history.
That's funny.
That people will click the alert box to see, and they'll see the drug listed under quote allergy or AE, and they don't click.
I know, and that's something.
And they just accept it. And then what happens is the template gets filled with that in there, and nobody looks.
Yep. I know. That's. I wish that somehow we could I've asked this question before, if we could make things make it mandatory that you put in a description, put the little mandatory star, and that wasn't something that we were able to do in CPRS, but if we could, then it would at least make people document something. The other thing that I'd like to point out with documenting is if a patient remembers absolutely nothing and has tolerated nothing at the VA and we didn't give them a beta-lactam, that is still valuable information for you too. So if that is the case, that's still worth updating as well. So it still helps you in the future when you're seeing that patient so that you're not repeating this work as well. And then the last thing that you can do if you really feel strongly about an allergy and you want to get it removed, Allergy has, at least as far as I know, they're still pleased with us doing this. We're placing outpatient allergy consults to them for penicillin skin testing and further allergy assessments. So that's something that you can always do for your patients before you sign off on them as well. So here, I won't go through each of these, but sometimes when we, from a pharmacy standpoint, when we ask questions, these are the types of questions we typically try to ask, see if they can tell us the specific medication that they can take, or at least maybe what route it was administered, because that might help. But a lot of times they have no idea. Maybe see if they can tell you how long after taking the med the reaction occurred, or how long it lasted. Ask them to describe the reaction, what they can remember. If they required any medical treatment, that can also clue you into how severe the reaction was. We always try to ask them if they were taking any other new meds. So sometimes you start 3 or 4 meds at the same time and you don't know which one, so we'll see if they know that. And then have they ever tolerated the same medication or a medication in the class? And we usually try to provide them examples. So like Dr. Ayler does the pink stuff, or we'll give them a couple names and see if they recognize any of them. And the vast majority of the time, the patient's going to tell you, I have no idea. But it's worth asking, because sometimes they may recall some information there. And then this was just essentially a study that supports the use of beta-lactam allergy testing in either in the inpatient or the outpatient setting. It just really increases the odds of patients actually getting preferred therapy, so it's still a valuable option. And then the last part, and we've talked about this a bunch, is just delabeling allergies. And this is something that's very, very difficult. So if you have a patient, and I did this a couple times with our team, we had a couple patients that we gave, we had somebody with a penicillin allergy and we gave them Zosyn. So I actually I marked it as entered an error and I documented everything, and there's an allergy note in there as to why I removed the allergy. The patient clearly tolerated a penicillin, so I took it out. So feel like if you give somebody a penicillin and you have the opportunity to remove the allergy altogether and you feel comfortable doing that, you can do it. If you feel like you want allergy involved, you can always ask them to see the patient to do it as well. But the reason that this is such a huge problem is in the VA system, fortunately, we're all linked together. So you remove it from their inpatient setting, they go to their PCP, and it's removed. So now the PCP is aware they have options. But when you're not in the VA system, in the private sector, they see every different specialist, and you really have to make sure if you remove it, you educate the patient too, so that they know they can tell their other doctors to tolerate it. And that's something that's difficult. And even in the VA, we deal with some of it because they see multiple VA sites. So they may have remote allergies, and I've seen this happen 1,000 times too. We remove it, we document why it was removed. The patient went to another VA and came back, and a remote allergy to penicillin flags, and somebody puts it back in. And so we do our best to reach out to those VAs, and sometimes I can get them to remove them. Sometimes they're like, we don't have an allergist here, we'll document it, but it's gonna stay in the chart. So it just depends on the system. But making sure that the patient understands that the allergy was removed and it's safe will help potentially with delabeling at all of the different sites that they see. So that's pretty much it. So just to wrap it up, you guys know this as well as I do, that distinguishing drug rashes from non-drug rashes can be difficult. So really just understanding, is this a true allergy or not when you're seeing a patient that has an active allergy. And then knowing that the rate of true IgE-mediated allergies is low. So just making sure you ask the patient what happened, because it can help you make better decisions there. And then make sure you just remember how to use that table, because it will really help you pick agents in the future. I use it probably at least 2 or 3 times a week. And then just your key points, they're here. I would just say try to incorporate allergy assessments into your daily practice in patients that have penicillin allergies, and update them when you can, or call your pharmacist and ask them to potentially help you update it. And then just don't hesitate to ask your ID pharmacist for questions if you don't know how to do something, because this is a problem that's probably not going anywhere.